Hello guys and welcome back to Counter 10. My name is Ani and on today's episode we're going to be covering the endocrine functions of the kidney as well as looking at the glomerular and tubular function of the kidney. This is our second episode in our renal physiology topic, and like I said in the last episode, I find renal physiology a particularly hard topic to cover. And the reason I feel that way is because I think when you look at all the LOs, they never really made much sense to me in the way they were structured, and it felt kind of disjointed when I was trying to piece together all the information. So with today's episode, I've rearranged some of the learning objectives to hopefully make it a more structured learning process for you. We're going to start off looking at the endocrine function of the kidney, but we're not going to delve too much into the RAS today, as we're going to save that for our next episode. Then we're going to look at glomerular filtration, followed by looking at tubular function. And when we look at tubular function, we'll go back and look at the way the kidney handles reabsorption of electrolytes, glucose, nitrogenous products, and then finish off by looking at the renal control of acid-base balance. What I won't cover in today's episode is looking at the countercurrent mechanism, which we'll save for our next episode, where I'll cover the control of urine production as well as applied renal physiology. And that'll be our last episode in our renal physiology series. As always, at the end of the episode, I'll look at the past SAQs related to the topics today, and with that said, let's dive straight into it.
1, 2, 3, 4.
So to start today's episode, we're going to look at the function of the kidney and our first learning objective, which is outline the endocrine function of the kidney. Before jumping into the endocrine function of the kidney, you can broadly classify the different roles of the kidney by saying it has regulatory roles, excretion roles, acid-base regulation roles, metabolism roles, and then endocrine roles. Within all these roles, you can argue that the regulatory role in maintaining water, electrolyte, plasma volume, osmolality, and blood pressure balance is the most vital, but the other roles are also important to know of. And that's because sometimes you get broad SAQ questions that ask you what are the roles of the kidney, and we'll cover an example of this in our later section. Focusing back on the endocrine roles, you can think about looking at the endocrine roles of the kidney in two ways. You can either divide it in your head as the hormones that either act on the kidney or the hormones that are produced by the kidney. Now, there are a lot of hormones that act on the kidney, and some of these include angiotensin II, aldosterone, ADH, ANP, parathyroid hormone, and then circulating catecholamines. And then hormones that are produced by the kidney involve chiefly renin, calcitriol, EPO, prostaglandins, and then your kallikrein. Out of all of these, you have to know renin well, and we'll focus more on the hormones that are produced by the kidney here rather than the hormones that act on the kidney. So looking at renin first, renin is a glycoprotein made in the juxtaglomerular apparatus within the granular cells. It's secreted and released when there's a decrease in renal blood pressure, when there's a decrease in the tubular sodium chloride concentration, when there's activation by circulating sympathetic catecholamines or the sympathetic nervous system, and by prostacyclin. And you can appreciate now why the anatomy is so important. Being located in the juxtaglomerular apparatus means that it's really closely linked to the afferent arterioles. Therefore, it has the information it needs very closely available to then secrete renin. And when renin is secreted, it goes and cleaves angiotensinogen into angiotensin 1 in the liver. And angiotensin 1 then gets converted into angiotensin 2 via ACE in the lungs. And this leads to a whole host of responses in our RAS system, which we'll talk about in our next episode, but broadly speaking, lead to an increased reabsorption of sodium chloride, lead to an increase in water content, lead to a change in renal blood flow and a change in GFR, improve the blood pressure through vasoconstriction, further activate the sympathetic nervous system, but also, importantly, has a negative feedback loop within the whole system. Within this negative feedback loop, it's important to know that angiotensin II leads to a decrease in renin release, as a way to control that system to stop it from going into overdrive. Among the other hormones produced by the kidney, you have calcitriol, which is a steroid hormone that makes active vitamin D. Vitamin D3 is made in the skin via UV light and is hydroxylated in the liver to 25-hydroxycholecalciferol. In the proximal nephron, you have 1-alpha hydroxylase, which is stimulated by the parathyroid hormone and makes the cholecalciferol into 1,2,5-dihydroxycholecalciferol, which is the active form of vitamin D. This active form will then increase the plasma calcium levels and the phosphate levels by increasing bone reabsorption, increasing the distal renal tubular absorption of calcium and phosphate, as well as increasing the small bowel reabsorption of calcium. Then you have EPO or erythropoietin, which is a glycoprotein which is mainly produced in the kidney, but a small amount, 10%, is also produced in the liver. It's made in the peritubular capillaries, specifically in the endothelium, in response to a decreased renal partial pressure of oxygen. The other triggers also can be anemia, as well as a decrease in renal blood flow. It's the main regulator for red blood cell production in the bone marrow, and it stimulates the red blood cell precursors, as well as enhances the red blood cell maturation process. Then you have prostaglandins, which we said were the important opposers to all the hormones that cause the vasoconstriction at the afferent arterioles. These are a product of our arachidonic acid pathway and are important to dampen that vasoconstrictor effect on the kidney. They inhibit the mesangial cells from contracting, and they can also be a minor trigger for renin release in the context of increasing angiotensin II to try to maintain GFR. Then the final hormone is kallikrein, and kallikrein converts kinagens into active kinines. The most obvious example is bradykinin. These active kinines have vasoactive properties, especially on the vascular smooth muscle, that leads to relaxation, leading to vasodilation, as well as increasing renal blood flow. And technically speaking, kallikrein and renin are both enzymes that initiate hormone production downstream, while calcitriol and EPO are more your conventional hormone. So that's our first learning objective done, and now we'll look at glomerular and tubular function, with the first learning objective here being describe glomerular filtration and tubular function, which is really two separate learning objectives. Let's first focus in and look at glomerular filtration. We can define glomerular filtration as the filtration from the glomerular capillaries into the Bowman space. And when we think about this from an anatomical level again, remember we have three components to our renal corpuscle, and they're all important in playing a role in glomerular filtration. The first component is our glomerular capillaries, which on the endothelium of these capillaries has fenestrations which are very fine, between 70 to 100 nanometers, that allow only specific things to pass through. Then you have the basement membrane, which is a type 4 collagen, and you can have specific diseases related to this, like Goodpasture syndrome, but it's important to note that the basement membrane is a negatively charged membrane. Then you have the Bowman's space, which is within the Bowman's capsule, and remember in that Bowman's capsule, you also have filtration slits that are small, 20 to 30 nanometers, that are acting as another form of a filtration barrier. Surrounding all these three structures are your mesangial cells, which are contracting or relaxing, changing the surface area available for filtration. So knowing the anatomy allows us then to better appreciate how we can quantify the glomerular filtration rate. And we say that the typical equation for this is that the rate of filtration is equal to the surface area times the hydraulic permeability times the net filtration pressure. Now we can't really measure the surface area and the hydraulic permeability easily, so we say instead this is a filtration coefficient referred to as Kf. So then we can now rearrange this equation and say that the glomerular filtration is equal to the constant Kf times the net filtration pressure. So then what is the net filtration pressure? Well, the net filtration pressure, or the NFP, relates back to our Starling forces, which we covered all the way back in cardiac physiology when we looked at regional circulation. Starling forces, or the Starling equation, describes the net fluid movement across a semipermeable membrane, where the two forces important in this equation are your hydrostatic forces and your oncotic forces. On one side of the membrane, you have the glomerular capillary, and on the other side, you have the Bowman's capsule or the Bowman's space. Each one of these sides has an associated hydrostatic pressure as well as an oncotic pressure. And when we write out this equation, we say that the net filtration pressure is equal to the filtration coefficient times, in brackets, the hydrostatic pressure within the glomerular capillary minus the hydrostatic pressure in the Bowman's space, close brackets, minus the reflection coefficient times, open brackets, the oncotic pressure within the glomerular capillary minus the oncotic pressure within the Bowman's capsule. And this is a really important equation to know because you need to write this down in SAQs, but you also need to be able to explain it in Viva settings. Now we can look at each one of these variables in further detail, starting off with the hydrostatic pressure within the glomerular capillary. This is heavily influenced by the renal blood flow, but in normal circumstances, this will largely be unchanged due to the autoregulation that we described in our previous episodes. If you increase the afferent arteriole dilatation or you constrict the efferent arteriole, this will further increase the hydrostatic pressure within the glomerular capillaries. And the opposite is true if you constrict the afferent arteriole or dilate the efferent arteriole. This will decrease your hydrostatic pressure within your glomerular capillary. Normally we say there's very little change that occurs within this pressure. At the start, the pressure is roughly 60 millimeters of mercury, and at the end, it's roughly 58 millimeters of mercury. In comparison, the hydrostatic pressure within the Bowman's space stays constant under normal conditions because there should be nothing that's increasing that pressure as long as filtration is occurring smoothly down the tubule. If you get obstruction downstream, which will increase retrograde urine flow, this could be one cause of increasing the hydrostatic pressure within the Bowman's capsule. But generally we say this is constant at 15 millimeters of mercury at the start of the afferent arteriole, and at the end, it's still 15 millimeters of mercury. So the only thing that really changes is the oncotic pressure within the glomerular capillary, because the oncotic pressure within the Bowman's capsule is negligible because proteins can't cross into this space. So at the start of the afferent arteriole, the oncotic pressure is 21 millimeters of mercury, but by the end, it's 33 millimeters of mercury. And this leads to a net filtration pressure, an average of 17 millimeters of mercury. And this 17 millimeters of mercury of average net filtration pressure is enough to produce 180 liters per day of glomerular filtrate. And the way we come up with that number based on knowing what our filtration fraction is. Now, the only two variables that we haven't covered in this equation are our filtration coefficient and our reflection coefficient. With regards to our filtration coefficient, we've already said this is the surface area times the permeability. So these are the two variables we can change to change our filtration coefficient. The way the surface area can be manipulated is by altering the contraction specifically of the mesangial cells. If you increase the contraction, you decrease the surface area. A decrease in surface area means a decrease in GFR. This will occur in response to release of things like angiotensin II, ADH, NORAD, while relaxation of the mesangial cells will increase the surface area and increase GFR. And the classic example of things that do this is ANP. When it comes to permeability, the two factors that can change permeability are determined by the size and the charge of the particle that's trying to pass through these areas. We typically say with size, anything less than 7,000 Daltons will freely pass through. Anything that's between 7,000 to 70,000 Daltons will be filtered on a linear scale as the size increases, while anything above 70,000 Daltons will not pass through and not get filtered. With regards to charge, the importance of knowing that the basement membrane was negatively charged was that other negatively charged substances will be repelled by this barrier, while positively charged cations will be more favorably filtered. And a good example to know for this is that albumin is technically only 66,000 Daltons, but because it's negatively charged, it is not filtered by the kidney in normal circumstances. So when you have a healthy kidney, you shouldn't be seeing any albumin in the urine. And this links in nicely into talking about reflection coefficient, which is the last variable in this equation. The reflection coefficient describes, on a 0 to 1 scale, the permeability of the membrane to a specific solute. Most often, when we talk about the reflection coefficient, we're talking about its permeability for proteins. In the kidney, the reflection coefficient is 1, which means that proteins are highly impermeable across this membrane, which makes sense because we don't want to lose these proteins in the kidney. In comparison, a reflection coefficient in the liver is close to 0 because proteins need to easily pass through the membrane because they're both produced in the liver and then stored in the liver. So these are all the important variables when we look at the net filtration pressure equation. In summary, what it's trying to say is that the main driver for filtration is going to be our hydrostatic pressure within our glomerular capillary, and opposing this will be the hydrostatic pressure within the Bowman's capsule, which is a constant, and the oncotic pressure within the glomerular capillary. Overarching these factors is our filtration coefficient, which is going to be affected by our surface area and our permeability, which is a combination of the size of the molecule and the charge of the molecule. The reflection coefficient in a healthy kidney should be equal to 1, therefore shouldn't really impact the filtration rate, but as the kidney gets damaged, that reflection coefficient might change. Another term that you might see that gets linked in with glomerular filtration is the filtration fraction. And this is something we touched on last episode when we said that the filtration fraction is the GFR divided by the renal plasma flow, which is equal to 20%. Now, I'll briefly mention this now because remember, substances can have varying effects on either the afferent arteriole or the efferent arteriole. So something like angiotensin II, which is a potent constrictor of the afferent and the efferent arteriole, has a bigger constricting effect on the efferent arteriole. And this leads to an increase in filtration fraction. And if there's an increase in filtration fraction, there is invariably an increase in GFR. So while renal blood flow has been decreased, the reason that GFR and filtration fraction has been increased is because you've increased the hydrostatic pressure through that glomerular capillary bed. And knowing this, we can then therefore say that the main driver for glomerular filtration is going to be that hydrostatic pressure within that glomerular capillary. So that covers glomerular filtration in a nutshell and moves us on to then look at tubular function. And I think this is a lot more trickier than understanding glomerular filtration. To help us understand tubular function, I'm going to integrate another learning objective, which is describe the role of the kidney in the handling of glucose, nitrogenous waste products, and drugs. When you first think of tubular function, you can either divide it in two ways. You can think about what's happening in the tubule at each distinct anatomical point, being the PCT, the loop of Henle, the DCT, and collecting duct, or you can think about it as what's happening on a microscopic level within the lumen, the tubule cells, the basement membrane, the interstitium, and within the peritubular capillary. Overall, regardless of the way you break it down, there are only 4 basic excretory processes of the kidney: filtration, which we've just spoken about; secretion, which is the transport of substances from the peritubular capillaries into the lumen of the tubule; reabsorption, which is moving substances across the lumen into the interstitium into the peritubular capillaries; and then excretion, which is the removal of the substance from the body. Because we know that the kidney filtration is roughly 180 litres per day, and 99% of it is reabsorbed, we can say that the main tubular function is reabsorption. And reabsorption can either happen two ways on a microscopic level. It can either take a transcellular route where it crosses the luminal and the basolateral membrane and the tubule cells, or it can take a paracellular route where it goes across tight junctions between the tubule cells. Depending on the pathway that substance is reabsorbed will then determine the mechanism of that reabsorption. And there's three broad mechanisms you can think of. There's simple diffusion that can either be facilitated or passive, and these are molecules that are carried down the electrochemical gradient. There's active primary transport, where molecules are carried against an electrochemical gradient by the use of energy in the form of ATP, and this way is predominantly used for small proteins that need to be reabsorbed back from the lumen through the process of endocytosis. And then there's active secondary transport, where two substances move across the membrane at the same time, but one goes down its concentration gradient, releasing energy, and the other goes against it. And this can either occur where both the molecules end up going in the same direction, or they're going in a counter direction called countertransporters. Now, some important terms to understand when it comes to reabsorption are two terms referred to as transport maximum and renal threshold. The transport maximum, or the Tmax, is the max amount of a substance a transporter can carry per unit time. And when a Tmax is reached, a transporter is saturated and the rest of the substance cannot be reabsorbed, so therefore will get excreted. In comparison, a renal threshold is the concentration of a substance in plasma at which transport saturation is apparent. These two terms sound similar, but they're slightly different, and generally we say that the renal threshold doesn't always equal the Tmax. Generally, the renal threshold is a bit lower than the Tmax, and this is because each tubule varies slightly on what the Tmax is. A great example of this is glucose. Generally, we can say that the Tmax for glucose is roughly 15 millimoles per liter, but the renal threshold is roughly 12 millimoles per liter, and that difference between its Tmax and renal threshold is referred to as a splay. Clinically, what this means, if you were to have less than 12 millimoles of glucose passing through the tubular lumen, it would all theoretically be reabsorbed and you should see no glucose in the urine itself. However, if you take drugs like a sodium glucose transporter inhibitor, which alters that transport mechanism and decreases both the Tmax and the renal threshold, now all of a sudden you might be seeing glucoseuria present when you previously didn't have any glucose present in the urine. So just remember those two terms, Tmax and renal threshold, because people love to ask them again in a viva setting. Now, to better understand tubular function, we can start to look at some common examples to help us understand how different parts of the tubule have different roles. Starting off with the most important substance, which is sodium. Sodium is a freely filtered electrolyte, and roughly 25,000 millimoles is filtered in a day. From that 25,000 millimoles, 99% of it is reabsorbed, and the majority of the energy needed in the kidney is used to reabsorb this amount. Sodium can be absorbed in all areas of the nephron except the descending loop of Henle. The principal site of reabsorption is in the PCT, where 65% of it is reabsorbed, and it's mainly reabsorbed either via co-transporters, being glucose or amino acids, into the luminal membrane and then across the basolateral membrane using the sodium-potassium ATPase exchange. This is using the transcellular route, and the other mechanism for the transcellular route is the countertransport with hydrogen ions. Importantly, the reabsorption of sodium is adjusted in the PCT via the glomerular tubular balance, which is different to the glomerular tubular feedback mechanism. And the basic reason this glomerular tubular balance exists is to ensure that the sodium reabsorption by the PCT is adjusted to match the GFR, so that if GFR increases, then the amount of sodium that's reabsorbed also correspondingly increases. And there's varying theories depending on what you read. So in Vander's, the way they describe this mechanism of action is that they state due to mechanicotransduction by the microvilli on the luminal surface of the PCT, as flow changes, the reabsorbative properties also change. However, in CAM, they describe two reasons for the mechanism of action. The first being, as GFR increases, you're also getting increased filtrate of glucose and amino acids, and this is co-transported with sodium back into the tubule cell and then reabsorbed. The other mechanism is that as GFR increases, you get increased protein-rich fluid and increased oncotic pressure in the peritubular capillaries, and this favors reabsorption. Now, I don't think you have to know about all these mechanisms, but importantly, just know that despite changing GFR, we're always absorbing around about 65% of the sodium within the PCT. Then you have reabsorption of sodium within the ascending loop of Henle, where 25% is reabsorbed, and this is mainly through active transport driven by the sodium, potassium, and 2-chloride co-transporter on the luminal membrane again, as well as the sodium-hydrogen countertransporter within the luminal membrane. Then in the DCT, specifically the early DCT, you get 5% reabsorption by specific sodium channels, and in the late DCT and collecting ducts, you get another 5% reabsorption. And this is the main site where aldosterone is having an effect. An interesting fact is that aldosterone is only affecting sodium reabsorption by a few percentages, which has a massive impact on the total amount of body water. Therefore, you only need sodium to be affected by 1 or 2% to have a big impact on your volume status. And that's why, as tedious as it sounds to know about the glomerular tubular balance, maintaining that constant amount of sodium that's being reabsorbed in the PCT in light of differing GFR is really important when you think about the whole body fluid composition. Then in contrast, we can talk about chloride as our next electrolyte. And the reason we talk about this is rather than taking the transcellular approach in the PCT to be reabsorbed, majority of chloride is reabsorbed by the paracellular route in the PCT. It again is freely filtered, and its reabsorption percentages closely follow the numbers of sodium. So 65% is reabsorbed in the PCT, and in the ascending loop of Henle, again with the sodium potassium 2-chloride co-transporter, 25% is reabsorbed. Within the DCT and collecting ducts, roughly 10% is reabsorbed, and there's different mechanisms in each. Within the DCT, you have specific co-transporters with sodium, and within the collecting ducts, you have specific type B intercalated cells. These type B intercalated cells have a chloride bicarbonate antiporter on the luminal membrane, which helps to reabsorb chloride. Then we have water, which is reabsorbed by diffusion through the cell membranes and through the tight junctions. 65% of water is reabsorbed in the PCT, so you can see a theme going that roughly 65% is the number you need to remember for any kind of solute to be reabsorbed in the PCT. 10% is reabsorbed in the descending loop of Henle. The difference with water is that the ascending loop of Henle is impermeable to water, which is important for the countercurrent mechanism, which we'll talk about in our next episode. Then in the collecting ducts, the amount reabsorbed can be varied depending on the amount of antidiuretic hormone having an effect, from 5% to 25%. And at rest, even in normal conditions, you need a degree of antidiuretic hormone to be having an effect of reabsorption, because without it, your urine output will be close to 20 to 30 liters a day. Then we have potassium, which is again freely filtered, and this is a Viva favorite. Normally, 55 to 60% is reabsorbed in the proximal convoluted tube again, mainly by passive transportation via the paracellular route, while 25% is reabsorbed in the ascending loop of Henle through the use of the sodium-potassium 2-chloride transporter. And then importantly, Within the DCT and collecting ducts, we have a few different cells acting to reabsorb and secrete potassium. The cells that secrete potassium here are your principal cells, and these are the cells that aldosterone is going to work on to help decrease the plasma concentration of potassium. When aldosterone gets activated, it increases the sodium-potassium ATPase activity on the basolateral surface of the membrane, driving more potassium into the principal cell, which then pushes potassium through the luminal membrane. Because this is a passive process of potassium going across the luminal membrane, it's highly varied depending on the tubular flow rate to wash away that gradient of potassium within the tubular lumen to allow that potassium to be secreted. Therefore, we normally say that the potassium secretion is dependent on aldosterone activity as well as the tubular flow rate. Later down in the pathway, in the collecting ducts, you have your type A intercalated cells, and these exchange potassium for hydrogen on the luminal membrane itself. So hopefully with these examples of common electrolytes, you can see how tubular function varies depending on which part of the nephron you're at, as well as what transporters exist on the luminal membrane as well as the basolateral membrane. This then moves us on to looking at our last part of this learning objective, which is looking at how glucose and nitrogenous wastes are handled by the kidney. We've already kind of touched on glucose when we talked about the concept of splay using Tmax and renal threshold, but just to reinforce it, we know that glucose is freely filtered, and under normal conditions, all of glucose which is filtered should be reabsorbed. There's no glucose that's secreted, and therefore the clearance of glucose is zero. And the reason I bring this up again is because sometimes people like to show you this diagram showing glucose filtration on the y-axis and plasma glucose levels on the x-axis. And what this graph shows is that differentiation between the renal threshold, which starts at roughly 250 milligrams per minute of glucose being filtered, and then the Tmax being reached at roughly 375 milligrams per minute of glucose being filtered. So it's a good diagram just to quickly look at, and it comes directly from Power and Cam. Then we have waste products like creatinine and urea, both of which we've touched on in our last episode. With creatinine, we know that it's freely filtered, but also a small amount is secreted into the lumen. No creatinine is reabsorbed, so creatinine clearance is slightly higher than GFR. In contrast with urea, this is more complex, and it's complex because it's important in the concentration and the dilution of urine. In general, urea is freely filtered, and roughly 60 to 50% is reabsorbed. The amount of reabsorption varies depending on the volume status and the amount of ADH that's present. In the PCT, 50% is reabsorbed by passive diffusion, but there's no reabsorption within the loop of Henle, the DCT, and the cortical collecting ducts, because this is impermeable to urea. In contrast, in the collecting duct of the medulla, this is permeable to urea, and a further 10% can be reabsorbed here. The degree of reabsorption here is really variable on the effect of ADH, because if ADH is high in a fluid deplete state, that increase in urea permeability leads to an increase in urea reabsorption, which leads to an increase in urea concentration within the inner medulla, helping to drive an increase in water reabsorption. This is the concept of urea recycling, and we'll talk about this when we look at the countercurrent mechanism as well as the concentration and dilution of urine in our next episode. Then we have the renal handling of drugs, cations, and anions, and this is relatively straightforward. With regards to cations, they can be actively secreted in the PCT, whether this is endogenous substances or exogenous substances. Example of endogenous substances are things like dopamine, acetylcholine, adrenaline, serotonin, while examples of drugs are things like atropine, morphine, pethidine, and all of these enter the lumen via the basolateral membrane using a family of transporters known as the organic cation transporters. Similarly, when we look at anions, they're also secreted in the PCT using a family of transporters known as the organic anion transporters, and these can be endogenous substances like bile salts, fatty acids, oxalates, and urate, or exogenous drugs like acetylamide, furosemide, penicillin, sulfonamides are all secreted in the PCT. And that's really all you need to know about drug handling in the kidney without going into specific details with each example. So to finish off our learning objectives today, we're going to look at one last thing, which is the renal control of acid-base balance. And this will hopefully tie in a few of these concepts we talked about when we looked at tubular function. To understand the renal control of acid-base balance, you have to understand how the kidney handles predominantly bicarbonate and hydrogen ions. Remembering that the body is an open system when it comes to acid-base balance, and that you have many buffers in the body for acids. Acids can either be volatile acids, that is, those that can be eliminated via the lung, or non-volatile acids such as lactate that cannot be excreted by the lung. And we can think about these non-volatile acids as fixed acids, and this is where the kidney plays a role. Its main role is to eliminate these fixed acids which can't be eliminated via the lung. So then how does it do this? Well, when we look at bicarbonate is freely filtered by the kidney, and majority of it is reabsorbed under normal conditions. In a normal kidney, roughly 4,000 millimoles a day of bicarbonate is filtered out. In comparison, only a very small amount of hydrogen ion, 6,000 nanomoles per day, is filtered out by the kidney. To help ensure that all of the bicarbonate is reabsorbed, we need more hydrogen, and so the major source of hydrogen into the tubule is via secretion. So hydrogen can be secreted using our luminal membrane H-ATPase pumps, our sodium hydrogen countertransporters, and then later on in the collecting ducts are intercalated cells. So all this extra increased hydrogen that's secreted into the lumen helps to reabsorb the bicarbonate, majority of which is reabsorbed in the proximal tubule, roughly 85%, and 10% in the thick ascending loop of Henle. The way that bicarbonate is reabsorbed is that within the PCT, along the brush border cells, you have a higher concentration of carbonic anhydrase to make carbonic acid, which then dissociates into water and CO2, both of which can be freely absorbed in the PCT. And once absorbed in the tubule cells, again there's carbonic anhydrase, which reverses this process so that bicarbonate is reabsorbed within the basolateral membrane, and that hydrogen again, using the H-ATPase pump, is pumped back into the lumen to repeat this process over again. This process, however, is not excreting any hydrogen ions. Instead, it's ensuring that all bicarbonate is reabsorbed. Once all the bicarbonate is absorbed, any excess hydrogen that's lost is now equivalent to having a new bicarbonate. And at first this sounds a bit tricky to understand, but what we're trying to simply say is that you can't get rid of an acid until you reabsorb all the bicarbonate. Once you reabsorb all the bicarbonate, that hydrogen acid can now be excreted. And the two ways that hydrogen typically gets excreted is one, firstly by binding to phosphate later down the tubule, and this combined phosphate with hydrogen does not get reabsorbed, so therefore it's a source of losing hydrogen. And in a normal day, you can lose up to 36 millimoles of hydrogen ions using the filtered phosphate. The reason why hydrogen needs to bind to something else that isn't going to be reabsorbed to be excreted out is because the lowest urinary pH we can have is 4.4. If the hydrogen was excreted without binding to something else, it would lead to a very acidic urine which will just burn as you pee. And when the pH gets to below 4, the process of secretion of hydrogen ion into the lumen actually stops. The other substance hydrogen can bind onto is ammonia. Ammonia initially comes from breakdown of proteins in the liver. The breakdown of proteins produces glutamine, which is filtered in through the kidney. The glutamine gets absorbed by the tubule cells, where it gets broken down into ammonium and bicarbonate. That bicarbonate is a new bicarbonate that's been produced and gets reabsorbed by the basolateral surface. In contrast, The ammonium that's produced gets pushed in to the luminal surface in exchange for sodium. The ammonium is a weak acid and it quickly dissociates into ammonia and a hydrogen ion. But some of that ammonia will seep out into the interstitium and then enter the collecting duct later on. And where it enters the collecting duct, it can rejoin to a hydrogen ion and therefore excrete hydrogen this way. And this process is referred to as ammonium recycling. And this system has a bigger capacity to excrete hydrogen compared to phosphate itself. So this way of buffering hydrogen ions onto substances that can't get reabsorbed is the way we get rid of our fixed acid load in a day, which is roughly around about 1500 millimoles per day. The caveat to this being, you need to reabsorb all the bicarbonate, and then once all the bicarbonate is reabsorbed, the leftover hydrogen is excreted. And this is exactly what the kidney does in response to a metabolic acidosis. In a metabolic acidosis, the amount of filtered bicarbonate is reduced because this is being used to buffer throughout the body. Because of the low plasma concentration, the tubular secretion of hydrogen is enough to reabsorb all that bicarbonate, meaning that the leftover hydrogen can either bind to phosphate and be excreted because phosphate won't be reabsorbed, or bind to ammonia and be excreted as ammonium. In this state as well, the ammonium production is also increased by the kidney because remember, when you produce an ammonium within the tubular cell, you're also producing a new bicarbonate by excreting that hydrogen ion in the urine as either phosphate or ammonium. So therefore, at the crux of it all, we always say that we only produce new bicarbonate when we get rid of a hydrogen ion. So that's all the LOs I wanted to cover today. And while it may seem a bit disjointed, what we haven't discussed yet, but we'll discuss on the next episode, is the countercurrent mechanism, the control of urine production, and then the applied renal physiology. But to finish today's episode, let's look at some of the past SAQs related to the topics that we've covered. I know we're already up to 40 minutes in this episode, so I'm going to try to go through these SAQs relatively quickly, going from the latest papers all the way back to the oldest papers. The first SAQ we're going to look at is from 2025 first sitting, which was a two-parter. Firstly, explain how hypoventilation causes respiratory acidosis, 25% of the mark, and outline how renal compensation for respiratory acidosis occurs, 75% of the mark. This had a 40% pass rate, and there's no model answer on MAC 95 yet. But using the examiner report, the key domains you needed to answer included linking hyperventilation to acidosis with relevant changes in blood chemistry, renal handling of acid load, specifically talking about titratable acidity and ammonium excretion, and then lastly, the renal role in bicarbonate regeneration. Better answers included an explanation of the Henderson-Hasselbalch equation and its relevance for volatile acids, an outline of bicarbonate reabsorption, with often a diagram for the proximal tubule was useful, an outline of titratable acidity and the phosphate buffer system, and on the flip side, the main problems seem to be confusion about what the term buffering and compensation means, confusing the bicarbonate buffer system with the Henderson-Hasselbalch equation, and then including irrelevant details about CO2 affecting ventilation. So in my attempt to make a model answer for this question, I would start off with a brief definition of acidosis being an accumulation of acid in the body, while acidemia describes the pH in our bloodstream being less than 7.35. The simple way to describe why respiratory acidosis occurs with hyperventilation is by using the Henderson-Hasselbalch equation, where pH is equal to 6.1 plus the log times in brackets on the numerator the bicarbonate divided by 0.03 times the partial pressure of CO2. With hypoventilation, you're getting an accumulation of the CO2 because you're not breathing this out, and as that CO2 increases, your pH will decrease. And this relates to your carbonic acid equation, where you have CO2 with water making carbonic acid dissociating into bicarbonate and a hydrogen ion. Those increased hydrogen ions need to be buffered, and that's when you get renal compensation occurring, which is your tie-in to the second part of this question. Now, we've already discussed the renal handling of acids, so I'm not going to go over it again, but the only thing I haven't touched on is this term titratable acidity. What it refers to in simple terms is the portion of acid in the urine that is buffered by a non-bicarbonate urinary buffer, and the main one that we spoke about was phosphate, while ammonium is not technically a titratable acid. And this is because ammonium has a very high pKa, roughly 9.2, so that means it doesn't release a proton when it gets titrated to a pH of 7.4. So titratable acids are those that release a proton when their pH goes back to normal baseline. And this term really confused me, and it comes from laboratory settings where titratable acids is a way to quantify that if I put a strong base in my urine, how much strong base do I need to bring that pH of that urine back to blood pH of 7.4. Now, when we think about titratable acids, we mainly think about phosphate because it's the primary buffering system under normal conditions. There can be other minor titratable acids, aka urinary buffers, such as creatinine, sulfates, and keto acids, but phosphate is the main one. And phosphate binds that hydrogen ion and then cannot be reabsorbed by the tubule and is therefore excreted in the urine. And remember, whenever you excrete a hydrogen ion, that's when the body makes a new bicarbonate. But to complete this answer, you can't just talk about phosphate alone, you have to talk about ammonium, because phosphate's capacity to buffer is very limited in acute and chronic acidosis settings. The capacity of the body to make more ammonium from glutamine breakdown is a way better buffer system in acute acidosis. And when that glutamine gets broken down, that ammonia goes into the lumen where it then becomes ammonium when it binds to hydrogen ions. And when that ammonium leaves the system, again, losing that hydrogen ion produces the bicarbonate. Because from glutamine breakdown itself, you're making a bicarbonate as well as a hydrogen which is being secreted into the lumen. So to be honest, this question, while on the face of it looks very straightforward, I think it's really tricky to answer and probably why it had a less than 50% pass rate. The key things you want to cover are that Henderson-Hasselbalch equation, linking this to compensation, talking about bicarbonate reabsorption, and the formation of new bicarbonate only when a hydrogen ion is lost, either through the phosphate system, being a titratable acid, or through the ammonia system, which is technically not a titratable acid, but has a way better capacity in either acute or chronic acidosis setting. And with that, we'll move on to our next SAQ, which was asked in 2024 second sitting, again a two-parter, the first part being describe the renal handling of glucose, and the second part, describe the physiological consequences of glycosuria. This had a 57% pass rate, and the examiner report here I think is really good, because prior to getting asked as an SAQ, this was a very common renal specific viva that you could get on the day. And the examiner report breaks down exactly what you need in the two parts of this question. With the first part, they say that you need to mention that glucose is freely filtered at the glomerulus, that reabsorption occurs in the proximal tubules by secondary active transport together with sodium and against the concentration gradient for glucose via the luminal SGLT2 transporters. The gradient for sodium is generated by the basolateral sodium-potassium pumps. There is a transport maximum for glucose reabsorption, and glucose leaves the cell via the basolateral GLUT2 transporters through facilitated diffusion. For part 2, the effects you need to mention were effects on osmotic diuresis with loss of water and electrolytes, as well as loss of an energy substrate. In this question, you can get extra marks really easily by talking a bit more about the transport mechanisms, having a graph to supplement that explanation, understanding the key term splay, and then briefly talking about the concept of SGLT2 inhibitors in clinical practice, which allowed you to link in part 2 a bit easier. I think of all the model answers for this question, either pick Propofol Dreams or Amanda Diaz as your two go-tos. And with this, I would divide the question for my model answer just as part 1 and part 2. starting off with the obvious and saying that glucose is freely filtered at the glomerulus and is primarily reabsorbed in the early PCT through secondary active transport. And what the examiner report meant with understanding the gradients was specifically understanding that the sodium-potassium ATPase pumps creates a gradient within the tubular cell for sodium to go down its concentration gradient from the lumen into the tubule cell, while glucose is going against its gradient because the concentration of glucose within the tubule cell is high. And the reason the concentration of glucose is high within the tubule cell is to make its gradient for the basolateral GLUT2 transporters, which are working through facilitated diffusion, so that glucose can be reabsorbed into the peritubular capillaries. Without this, if the glucose concentration within the cell was low, glucose wouldn't want to leave through those GLUT2 transporters because the gradient wouldn't be there to promote it entering the peritubular capillaries. And this was a question I got asked specifically in my actual Viva, understanding how SGLT transporters actually work. And you might have recognized that we talk about SGLT1 and SGLT2, but when it comes to the kidney, we typically refer to the SGLT2. Yes, there are SGLT1 receptors as well. These are located both in the bowel and in the kidney, but majority of glucose being reabsorbed in the kidney, specifically in the PCT, 80 to 90% of that glucose being reabsorbed is being done through the SGLT2 receptor, and that's why the drug blocks that receptor type, not the SGLT1 transporter type. Once you put that down, then you can talk about the term splay, which again refers to the difference in what you see as the Tmax for that substance versus the renal threshold. And that occurs because of the heterogeneity of nephrons in the kidney. Remembering that the Tmax for glucose is roughly around about 15 millimoles, while the renal threshold is roughly around about 12 millimoles per liter. So if the filtered load is below the Tmax, you should theoretically get complete reabsorption, while if the filtered load is above the Tmax, that's when you start to get glycosuria. And this can be the way then you connect the next part of this question, which is the consequence of glycosuria. Prior to you talking about that, I specifically wouldn't put in the graph displaying glucose filtration versus reabsorption because I think it's just too complex and you're just wasting time. Going on to the consequences of glycosuria, you can keep this short and simple, and I think there's nothing wrong with that for this question. With your first consequence being osmotic diuresis, and this occurs because glucose will exert an osmotic load within the tubules, and this will prevent the passive water reabsorption in the descending loop of Henle and then later on in the DCT and collecting ducts. What this means is that if you alter the water reabsorption, you're going to alter the ability to generate the medullary interstitial gradient, which we'll talk about in our next episode. This will therefore impact the ability to concentrate and dilute urine. And if you understand in clinical aspects what you see with a new patient that's been diagnosed with diabetes, they typically get polyuria. So with glycosuria, you would expect a high urine output, therefore a high diuresis, and secondary to that, you would expect the patient to be dehydrated. As a secondary consequence of that high urine output, you may start to get electrolyte loss, especially with normal reabsorption processes of sodium and potassium within the PCT, and this can then lead to hypokalemia or hyponatremia. You're losing an energy substrate in the form of glucose, therefore it has a metabolic effect on your energy stores, and then having high glucose in the urine puts you at a risk of UTIs and therefore infection. If you were doing well and had lots of time, this is when you could start to introduce the concept of SGLT2 inhibitors and talk about how this type of drug specifically is using some of the desired effects of glycosuria to have clinical outcomes. The examples being controlling blood sugar levels, controlling body volume status and diuresis in heart failure patients, particularly your HFrEF patients, and then on the flip side, the risk of these drugs in unwell settings leading to euglycemic ketoacidosis. I think if you cover all those points, you will easily cover what the examiner report wanted, and I think you could do this as a sub 10-minute question. Then our next SAQ is from 2022 second sitting, which was discuss the factors that determine glomerular filtration rate. This had a 47% pass rate, and the examiner report was pretty blunt, saying that this is a straightforward physiology question best answered using the Starling equation as the core framework. And it was difficult to pass this question if you couldn't demonstrate an understanding of this core physiological principle. The most common frequent error was asserting that renal blood flow directly determines GFR by conflating the common factors that influence both of them. Unfortunately, some people read this question as answering determinants of renal blood flow rather than GFR, and again, it's one of those things that comes up all the time. I remember it happening to me in my exam, reading questions the wrong way. Despite you telling yourself to read the question multiple times, it is very common to occur, specifically on questions that are very short like this, because your eyes read one thing, but your brain interprets another thing, and then before you know it, you're off writing. So just pause and give yourself a second wherever you can, just to double check before you start writing your answer. We're not going to spend too much time on the model answer for this question, because we know it relates to our equation for net filtration pressure, which is equal to the filtration coefficient times the sum of the hydrostatic pressure within the glomerular capillary minus the hydrostatic pressure within the Bowman's capsule, take away the reflection coefficient times the sum of the oncotic pressure within the glomerular capillary minus the oncotic pressure within the Bowman's capsule. You just have to go through these things one by one, understanding the main driving force for net filtration pressure and GFR, the hydrostatic pressure within the glomerular capillary. And we know this because this is related to our filtration fraction rather than our renal blood flow. Altering the afferent arteriole caliber will affect our hydrostatic pressure, but chiefly altering our efferent arteriole will have an even bigger impact on our hydrostatic pressure. And if you're struggling for time with this question, there's a few quick ways to get easy marks. Remembering that the filtration coefficient is a product of the surface area times the permeability, and that you can quickly write that surface area can be manipulated by the mesangial cells, and the permeability can be manipulated via the size and the charge of the particle. You can also get quick marks when talking about the reflection coefficient that in a normal kidney should be equal to 1. Then our next SAQ is from 2022 first sitting, which was briefly outline the physiology of the hormones produced within or activated by the kidney. Do not discuss autocrine or paracrine substances. This had a 60% pass rate and was actually my question in my paper, with the examiner report saying that the 3 hormones you needed to talk about were renin, erythropoietin, and vitamin D, and that the common error was a lack of detail to answer this question, and it was expected that you would talk about the production and activation pathway along with the triggers for release and the physiological effect of that hormone. So this is not a very hard SAQ to try to get a 3 on. It's probably a really hard SAQ to try to get a 5 because no one got a 5 in my sitting. But you can just start with renin because it's the easiest one to go over. Knowing that the source of renin is that it's produced in the granular cells within the juxtaglomerular apparatus within the renal cortex, and that its stimuli for release is chiefly low blood pressure but can be circulating catecholamines and sympathetic stimulation. Important to note is that it's inhibited by its negative feedback loop through angiotensin II, which is the final product of the RAS pathway. And that's how you would lead in to talk about the effects of RAS and what renin does. Then with EPO, it comes from fibroblasts within the renal cortex, and its stimuli for release is hypoxia, classically a low partial pressure of oxygen within the renal parenchyma. It's inhibited by the inflammatory cytokines, and the effect is that EPO helps to promote new red blood cell production as well as maturation of the red blood cell pathway. It does this through manipulation of the JAK signaling pathway, which I don't know how much you need to know about, but I think as long as you know the broad things that we've mentioned, that's more than enough. And the same then goes with vitamin D, which the stimuli for conversion is parathyroid hormone, and is producing that 1,2,5 dihydroxycholecalciferol via the action of 1-alpha hydroxylase, which is stimulated via the parathyroid hormone. Again, this is one of those questions that if you were time poor, which I definitely was when I was sitting my exam, and this was the last question on my SAQ paper, you can smash this out within 7 to 8 minutes, as long as you have a clear framework, which I think the framework from the user submitted answer is really good, which is having subheadings of source, stimuli, inhibition, and then effect of each hormone. This keeps you very on focus and ensures that you smash through this question. Finally, to finish off today, we have our last SAQ, which was asked in 2018 second sitting, that was briefly outline the functions of the kidney, and this had a 73% pass rate. Now, I'm not too sure if this question will be asked again, because the specific LOs have changed now to just talk about the endocrine function, but I still think this is a pretty fair question to be asked. The main feedback in the examiner report for this question was that you couldn't just focus in on talking about the water and electrolyte homeostatic functions of the kidney. You had to talk about extra things like drug and chemical biotransformation, talk about the metabolic processes, talk about things like erythropoietin and vitamin D that we just mentioned, and this would then give you a broader list and a better chance to pass this question. And if I was trying to make a model answer for this question, I would literally just copy the model answer from Propofol Dreams, which is a one-page fantastic answer for this question. And they divide the functions of the kidney into 7 roles. The first one being excretion of metabolic waste and foreign substances, the second one being regulation of water and electrolyte balance, the third being regulation of plasma osmolality, the fourth being regulation of acid-base balance, the fifth being regulation of blood pressure, the sixth being endocrine function, and then the seventh and final function being gluconeogenesis/metabolic. And with each one of these headings, I will just have 1 or 2 points, going back in reverse order, saying that with gluconeogenesis and metabolic processes, in states of energy need, the renal cortex has glucose 6-phosphatase, which has the ability to release glucose back into the bloodstream. With the endocrine function, you can talk about either EPO or vitamin D production. With regulation of blood pressure, this is both related to the RAS system as well as the kidney having its own set of intrarenal baroreceptors, of which we'll talk about in our next episode. With the regulation of acid-base balance, you can put in those key terms of removal of fixed acids, titratable acidity, and then the use of ammonium as a buffering system. With regards to plasma osmolality, this is just intrinsically linked to the reabsorption of water and solutes, and really you could just connect these two to the regulation of water and electrolyte balance and talk about how the filtration and tubular reabsorption functions of the kidney here without going into too much depth. And then to finish off with excretion of metabolic waste and foreign substances, this is one of the chief roles of the kidney. Typically, exogenous waste products are being secreted into the kidney so they can be excreted, usually in the PCT. The kidneys and the liver play a very important role, where the liver will do some biotransformation in phase 1 and phase 2 reactions to make something more water soluble so that the kidney can then remove it. And because this question has specifically said briefly outline, it is perfect for you to just talk about things very broadly. You don't need to know the minutiae details, but rather cover as many functions as you can to try to get a high mark, which is what people got with a 73% pass rate for this question. Now, even with a 73% pass rate, because this is such an important organ, it would be very fair for this question to be repeated again because it has important high clinical and physiological relevance. And with that said, that brings us to the end of today's episode. It's been a really big second episode in our renal physiology series, and that's why renal is a really tough topic to cover. But once you start to understand renal, you really start to see the interconnections between specifically cardiac and respiratory physiology. And that's when I first started to feel like I was actually starting to connect some dots and felt like I was actually getting somewhere when I was going through the curriculum. And with our next episode, hopefully you'll start to really feel that way when we really link in some more important concepts. So with that, Thank you all for listening, and I'll catch you guys next time on Count to 10.